All right, good evening, everybody. That was a trial, I must admit. So, Jeremy Hunt's my name. I've been talking to Trish, and we're going to have a chat live about body contouring and mummy makeovers. And I'm open to any questions. It's taken us a little while to technologically get there, but we're back in business. So, a few people have sent in a couple of questions asking about compression garments and whether they need to wear them for a long period after a tummy tuck. There's a few questions about breast implants and breast augmentations, and then what a lower body lift will do in terms of contour on the front and contour on the back. So I guess the first thing is that everybody is going to be an individual. So trying to come up with broad sweeping generalizations is going to be quite challenging. Everyone really needs to seek the opinion of a well-trained surgeon, and then they'll be able to get an individualized treatment plan that's going to suit their needs and their expectations. So my first piece of advice is always going to be, do your research, work out what it is you're actually after in terms of objectives. Then you're going to need to find yourself a surgeon who is capable of safely and effectively delivering you the best results possible. And my advice there is probably, given that we are all over the nation, to seek the opinion of the Australian Society of Plastic Surgeons, and they can direct you to a surgeon in your city or town who's going to be able to give you a good opinion. When it comes to mummy makeovers, there's a number of different procedures that sort of come under that umbrella. So quite often the terms used when we're referring to body contouring in the form of an abdominoplasty done in combination with a form of breast surgery. And then the breast surgery can be in the form of a breast reduction, it can be in the form of a breast lift, and it can involve a breast implant. And then trying to put that combination of procedures together, given that there are 4 or 5 different tummy tucks, and then there's 4 or 5 different breast procedures that may well then be combined with liposuction, means that you really do need to tailor the procedure to someone's specific needs. And then you can inform them as to the pros and cons, and then potentially they can decide to undergo the procedure. And if people are going to undergo a procedure, we just want to know that it's done once and done properly, which means you really do need a fully qualified surgeon, and it needs to be done in a fully accredited facility. So I've got some specific questions people have asked about different forms of body contouring. So I might kick off with those. When it comes to tummy tucks, it's a big operation, so patients need to be aware of that. And one of the questions was related to wounds after a tummy tuck that continue to, weep and break down. So surgery does put the tissue of the body under some stress, and then patients need to be mindful they need to be in a healthy, fit state to allow their body to heal as best it can. And then even in the best of hands, there will be times where wounds can be troublesome, and then it may come down to needing dressings to try and get a wound that's continuing to weep or break down to heal. And every surgeon will have their own approach to getting the best results for their patients, and surgeons will give their patients instructions on what to do. And it's really important that you actually follow the guidelines of your surgeon, because your surgeon really does want you to get the best results possible. So one of the things that we do have after a tummy tuck is going to be the compression garment. And people have asked, why do they need to wear a compression garment and how long do they need to wear it for? So that if you're doing body contouring work, you're going to want to have the minimum swelling and the minimal bruising. So if you think when someone sprains an ankle, they may strap the ankle, then the compression garment is going to much be like that. It's going to be designed to keep the swelling to a minimum, keep the bruising to a minimum, and that way people will make the fastest recovery possible. And then how long do you need to wear it for? It's going to be most important in the early phase after you've had the procedure, and then it's going to be sort of not as important, but still it's going to be beneficial in the weeks afterwards. So my preference is going to be to ask my patients to wear it pretty much day and night for the first 2 weeks, and then at night time potentially for another 2 weeks. And then some patients report back to me that they actually quite enjoy the garment. It gives them a sense of security, makes them feel that everything's in the right place, and they do find themselves wearing it for prolonged periods. So there's certainly no downside from wearing a garment, but there are certainly some definite upsides. So strongly advise people follow the advice of their surgeons, as we're all individuals. We'll all have slightly different guidelines as to what patients need to do. There's been a few questions from people about lower body lifts and circumferential body lifts, particularly about flattening of the buttocks or flattening of the bottom, and that can happen when skin is pulled tight. And then some of us will have techniques designed to, augment the buttocks at the time of the body lift, and that's something that I do think is quite important, something that's a big part of my practice. And what we're really looking for is to try and get the best results possible. And that is going to be addressing excess skin as well as achieving the best contour we can. And a flat bottom is not necessarily a desirable contour, particularly in a female form, so that we will use techniques to try and augment the buttocks using the patient's own tissue. And there are different options described. Some of them will involve using your own tissue in the form of a flap, a buttock augmentation flap, and that's the technique I like to use. And then the other option is going to be to transfer fat in the form of fat grafting. So again, it's one of those ones where each surgeon will have their own technique, they'll have their own philosophy on what the objectives of surgery are going to be. And then sitting down with your surgeon, it's a case of matching their philosophy and their vision with your desired outcome. And then if everyone's on the same page, then it's time to start thinking about heading to an operating theatre. So one of the other questions that we get asked a lot when it comes to body contouring and mummy makeovers is going to be breast surgery and the role of a breast implant and the location of the implant. So one of the terms that's bandied around a lot now, it used to be used in sort of medical literature, but it's pretty commonly used now, is that term dual plane. So a lot of people get confused when they talk about in front of the muscle implants, behind the muscle implants, and then dual plane. So in front of the muscle means that the implant is going to be placed behind the breast tissue, but it's going to be in front of the pec muscle, the big muscle on the chest. And then when we talk about behind the muscle, we're really putting the implant behind that pec muscle to try and cover the upper part of the implant so that patients really don't see that step that they often find quite unsightly, that round stuck-on look that people describe as bolt-ons. So that going under the muscle will help sort of minimize that transition from chest wall to implant that creates that unsightly upper pole. And then dual plane is really just a better description of that, because the pec muscle is not going to cover all of the implant. It's only going to really cover the top part of the implant. So the bottom part of the implant will be underneath breast tissue and underneath skin and fat. And that's where the term dual plane comes from. So dual plane has different levels where we'll make decisions based on the desired outcome and based on what the patient wants as to how much we will lift up that pec muscle. So I do think people do need to sort of seek a very specialized opinion, and everybody is going to be different. And it's all about just being able to understand the patient's desire and then translate that into the right procedure to get people what they want. So I've just received a question that's related to base width diameter, which is a term, again, that gets sort of used a lot in breast surgery. And in a perfect world, we would like to try and hide the implant behind a patient's own tissue, so that when we talk base width diameter, we're talking about the width of an implant that is actually going to sit behind the breast tissue diameter, so that the edges of that implant are hidden. And that's an ideal sort of situation. Though quite often what we find is that patients will have a very narrow base diameter to their own breast, and then they're looking for a bigger volume, and we simply can't get that implant to fit behind that base diameter. So the base diameter of the implant will be wider than the breast. And it's an acceptable compromise if people want to achieve a certain volume, a certain size, but the price the patient then potentially pays is that the edges of the implant will be palpable, or you'll be able to feel them. And it's particularly going to be an issue where someone has a relatively small volume of breast tissue, which then creates a relatively wide gap between the two breast mounds that someone wants to have narrowed, so that we really can't fit the diameter of the implant behind the diameter of the breast. So the diameter of the implant will then exceed the base diameter of the breast. And if that achieves the narrowing of the cleavage, let's say, that someone desires, or the volume someone is looking for, then that's a compromise that we would make, and one that then you need to explain to the patient in terms of palpability to the edge of the implant. And then that may well be a very good reason to put the implant behind the pec muscle, so that there's a little bit more coverage, so that you don't really see and feel the edge of the implant. So the classic situation for that would have been in the days of Tori Spelling and her breast augmentation, where you could really see the edges of the implant in the cleavage because it was located without enough tissue coverage. And then the solution for her was to have the implant put in a deeper plane underneath the muscle, so that the muscle then covered the top of the implant. So it really does come down to a lot of individualized care and a lot of decisions that need to be made, between the surgeon and the patient in terms of what result they're looking for and what is going to be the compromise, because really there will be compromises with all breast implants, and the question is having the minimum compromise with the maximum upsides. So that sort of touches on breast implants, and patients quite often ask to, when we're talking about mummy makeovers, how long is it going to be until they're able to pick up their children? So if an implant is put underneath the pec muscle, then it's probably going to be about 6 weeks until people are able to put a big load onto that pec muscle. But it doesn't necessarily mean they can't pick up their children for 6 weeks. It just means people need to be cautious not to get in what I describe to my patients as an out of control situation, so that people are not going to be wanting to pick up their child for the first time with the big forearm swoop while pushing the shopping trolley through Coles. You want to have picked them up for the first time, so in the home, where potentially on the bed or on the lounge. And if people are sensible and something hurts or is uncomfortable, they just need to stop doing it. So for all my patients, I'll say, for the first 6 weeks, there are no out of control situations. And out of control situations to me means horse riding, skydiving, big wave surfing, and then potentially the one-arm swoop of the running 2-year-old across the aisle at Coles. And if people are sensible, they'll just listen to their own bodies, and they will make decisions about, what's tolerable for their body after an operation. And then the same sort of principle goes for activities after someone's had a tummy tuck. So if someone's had a tummy tuck and there's been tightening of the muscles in the tummy, then it's going to take a good few weeks until those muscles are fully knitted together. And in the shorter term, they're going to be held together by by stitches, and you do not want those stitches pulling or tearing. So things like, sit-ups and obstacle courses and tough mudders and things like that, they're a good, to my patients, they're a good 6 weeks after a tummy tuck before you start to get going in terms of really using those tummy muscles. But before that, it's again just being sensible. If it hurts, then stop doing it, and don't put yourself in a position where you can't just back off and stop. So the other question people want to ask is, how long are they going to be in hospital after they've had a tummy tuck? And then it really comes down to 2 things. There's really three things. There's 3 reasons to be in hospital. So number 1 is you need a painkiller that needs to be injected. So if you're requiring decent painkillers in the form of injectable pethidine type medications, then you're going to need to be in hospital. And most patients will probably need that sort of analgesia or painkiller for the first day or so. After that, the reason to be in hospital potentially is going to be drains. So some people are comfortable and happy going home with drains in, and I'm very happy for my patients to do that. But some people really aren't in a position to go home with drains in, so they'll stay in hospital until the drains are removed. And then the third reason is going to be that when you do get home, you do really need someone to be there to help look after you. You're going to have some requirements. There'll be a degree of immobility. So you're going to need to either have someone home, or you're not going home from hospital until you're able to look after yourself. So that period, depending on the type of tummy tuck, because much like breast surgery, there's 5 or 6 different tummy tucks out there. For some people, it can be 1 day. For some people, it might be 3 days. For some people, it might be 5 days. And then if we're talking about body lifts, circumferential body lifts, then the hospital stay can sometimes be up to 6 or 7 days until those drains are removed and people are then comfortable and confident enough to get around their own home, and just the simple things, just get to and from a bathroom safely. The perennial question that does get asked when it comes to all of these operations and tummy tucks is what's covered under Medicare, and Medicare has recently undergone some changes. So it's always changing. On the 1st of November every year, they reissue a new list of descriptors for the operations that Medicare will recognise. And there are criteria that people need to meet to, qualify for a tummy tuck or a body lift being a medical procedure. And at the moment, those criteria are really based on degree of weight loss and what a patient's BMI is. And then a BMI is going to be the ratio of your weight to your height. So that patients who have lost weight for the betterment of their overall health to a degree that Medicare recognises, which is a drop in the BMI of over 5, then in Medicare's eyes qualify for a form of abdominal contouring surgery. So that those criteria for who qualifies and who doesn't qualify under Medicare are again going to be very individual, because it's going to be related to each patient's weight, how much weight they've lost, and then in comparison to that particular patient's height. And these are the sort of things that get assessed at the time of a consultation. So we will sit down, we will need to, take a history as to weight gain, weight loss, do an examination, which will include height and weight, and then we can advise people as to whether they qualify under Medicare potentially for some sort of abdominal contouring surgery. And then the difficulties are going to be, where is that procedure going to be performed? So that although Medicare may recognise the surgery, it may not be able to be performed in your local public hospital, let's say, because we all work in different area health services, and different area health services will have different guidelines as to which procedures can be performed in that public hospital. But the significance of being recognised by Medicare is then that potentially private health funds have to recognise the medical need of that operation, and depending on the level of the health fund that each person is in, it then means that the hospital costs and the operating theatre costs may well be covered. There will be a portion of the surgical and a portion of the anaesthetic costs then covered. And part of the process at the end of a consultation for us surgeons is to, make sure we provide patients with fully informed financial consent. So during the consultation, we would make an assessment of the procedure that a patient desires. We would then make sure that that procedure is going to be appropriate for that patient. And then we need to provide them with some sort of financial consent where we can point out what is covered by Medicare, what is not covered by Medicare, and what the then out-of-pocket costs are going to be. And the out-of-pocket costs are what we in our industry refer to as the gap. And when it's put down and explained to patients like that, they start to get a better understanding of what is covered and for what reasons. But again, it's all very, very individualized. So each patient will have different requirements that will be potentially recognized and potentially covered, so that broad generalizations are very difficult. And I think that's part of the reason why there's so much confusion out there, because there's not a single straight answer to what seems to be, to everyone, a relatively straightforward question. Now, patients often ask about the appropriateness or the ability to combine procedures. So that we do often in mummy makeovers and body contouring, we will combine different procedures so that patients can achieve an outcome in terms of abdominal contouring and then breast rejuvenation at one surgical procedure. And it's really going to come down to just making sure that whatever is done once, done properly, and then done safely. And then everybody's going to be different, so that in patients who need more extensive abdominal surgery, it may not be as appropriate to add more procedures to that single procedure as it would be in someone who needs a lesser abdominal procedure. And then you need to make sure that when these procedures are added together, of course, the patient's requirements for healing will be increased. So we need to make sure the patients then don't have any background medical issues, so that if patients are diabetic or there are issues of cardiac disease or potentially smoking, then it wouldn't be as appropriate to add procedures together for that patient as it would maybe for, say, a fitter, younger patient. So those sort of decisions are ones that are made by different surgeons based on different reasons, and they're going to be applicable for individuals. And then again, it all seems to come down to getting assessed by someone with experience who can then guide you as to the most appropriate procedure for you. And then you need to make sure that procedure is done once, done properly, and then we get the best outcome possible. So I'm happy to take any questions from anybody who is listening. I'm happy to continue to address some of the questions that were sent in earlier. So if anyone does have any questions, I encourage you to, type away, because, there are all questions, in my mind, good questions. And I tell my patients this all the time. If someone needs an answer, then they're asking a good question. So please, any question I'm happy to field, and any question I would happily give an informed answer to. So one of the questions that was asked a little bit earlier today through Trish was, what is the most appropriate treatment for scars after surgery? And there is some evidence. There's a lot of research being done, because everyone does want the best result possible, the finest scar that they can possibly achieve. And there is some evidence that pressure on a scar is going to create a better result. So to achieve that goal, we will use silicone sheeting quite often. The pressure can also come in the form of just taping with a form of paper tape is often quite a good way to treat it. And then there are various scar creams that are silicone based that will, just by the nature of the thin layer that they put over the skin, they'll apply enough downward pressure to stop a scar raising upwards. So all of those treatments are going to be potentially beneficial, and they're going to be beneficial on different areas of the body. So for scars on faces, I quite often will use a silicone-based cream. For areas that are hidden behind clothing, silicone sheeting is going to be very useful. But for areas that are maybe more mobile, so if someone has an arm reduction, let's say, after weight loss, trying to get the silicone sheeting to stay on those scars that are up in the armpit is very challenging. So just paper tape and downward pressure will help. So pressure is one of the best tools we've got to try and get the best result after scarring. And then the other one that we do recommend is keeping scars out of the sun, so that a healing wound is reprogramming itself, and it will tend to pigment or upgrade the pigment cells in the scar if it's exposed to ultraviolet light. So that patients just need to be mindful that all of those grazes on elbows and knees that we all got as kids that went brown are going to be healing wounds that were in the sun too early. So that to try and minimize that pigmentation, try and keep recent surgical scars and wounds out of the sun for probably about 3 months, and that means clothing or some form of sunscreen. And really that way patients are going to get the best result possible. The question about breast surgery and the adverse result that people sometimes get is always a good one. So that as surgeons, we always endeavour to get the best results possible for our patients. And if patients do not get the results that they expected, then it sort of falls to the surgeon to try and work through that. And sometimes the surgeons will get results that we're disappointed by as well. And in those instances, patients may well need some form of surgical revision. So for patients who have got results that they're not happy with, I think the first port of call is always to go and talk to the surgeon who performed the procedure, and then have a feel for what that surgeon's sort of understanding of the problem is and what their feeling is about the likelihood of a surgical revision improving the situation. So we don't want to do operations that are not going to make the situation better. And there will always be times where patients may not be satisfied with the results of their surgery, but another operation may lead to more dissatisfaction. So not all results are potentially candidates for a surgical revision. So patients sort of need to understand that. The next category is going to be where the result really didn't meet the expectations of the patient or the surgeon, and then patients are a candidate for revision. And it's not uncommon to see this in breast augmentation surgery recently, and in any form of surgery. And again, I think the first person the patient needs to talk to about it is the surgeon, and just make sure everyone's on the same page. And then there's going to be a time where revision surgery is appropriate in terms of timing, and a time where it's just not the right time to redo another operation. So that scars and wounds tend to heal over about 12 months. So in the very short term after an operation, sometimes the best advice is going to be to sit tight and wait. So sometimes time is our best friend in terms of results, so that there will be swelling, there will be potential bruising, there will be potential stiffness and firmness in the tissue that does need to resolve, and that can take weeks, and then sometimes it can take months. So that it's very important to stay in touch with your treating surgeon through that period to make sure that everybody gets what they're looking for in terms of answers, because every question is a good question and it deserves a good answer. So that if patients are getting the answers they need, it helps them get through that sort of often difficult post-operative period where there will be swelling and bruising until we get to a point where wounds have matured and everything has settled. And at that point, it's time to start making assessment about whether we need to consider a revision surgery. And then revision surgery is potentially always going to be more challenging than the first time round operation. And that is often quite difficult because patients obviously are heavily invested in that second revision surgery going well. It's often quite demanding technically for the surgeon. And then the surgeon, if they perform the first operation, is also going to be heavily invested in achieving the result that they want for their patient. So that it is often quite challenging on a lot of levels. If patients do think, though, that they have got, a result that's not as good as they'd expected, and they do not feel that their surgeon is filling them with confidence in terms of the answers they're getting and the plan moving forward, then patients will often go and seek a second opinion. And a second opinion can be very valuable, of course, for the patients, because they will get a second set of eyes that will look at the situation and offer some sort of advice. They will also potentially be able to relay something back to their treating surgeon when another person that surgeon may have faith and confidence in is able to offer some input into the way forward to potentially get a better result. So it really does come down to communication, a lot of communication and open and honest communication, and trying to just formulate the best way forward. And patients need to just be reassured during that difficult period, and there always needs to be an open door with open communication as to what the next step forward is going to be. So that's my advice to patients who don't think that they're happy with the result that they've achieved. So I'm happy to take any questions from anyone who is listening. I've covered off on a lot of the questions that Trish had sent to me, and I think since I've just made it home after a fairly long day, and there are a couple of screaming kids in the kitchen that I need to go and sort of spend some time with, then I might wind this up. We're very easy to find. You can always contact Trish through the Plastic Surgery Hub, and if anyone specifically wants to ask me any questions, please we're readily available through the website. We're very easy to find, and it's been a pleasure. I hope that I've been able to maybe shed some light on some things people are confused or unclear about, and that hopefully it's been beneficial for people. So at this point on a Tuesday night with 3 weeks before Christmas, I'm going to say good evening to everybody, and get about being a dad and get back to the family. Look, all the best, and thanks for those who've tuned in.